Hello. For those of you who don't know me, I'm Mary Beth Weber, and along with Guillermo Pierres, we are the enrichment co-chairs of the Georgia Center for Diabetes Translation Research. Thank you to everybody in person and online who's joined us today for our annual symposium that I forgot what we call it. The Distinguished Lecture, sorry. It's been a busy week of grant writing. My brain's a little fried. But it is my great pleasure to introduce our speaker today. Dr. Ann Sumner is Section Chief at the Section on Ethnicity and Health, Diabetes in the Diabetes, Endocrinology, and Obesity branch. Venkat, stop causing trouble in the front row at NIDDK. After completing her medical training, Dr. Sumner did her residency in internal medicine before doing fellowships in both endocrinology, diabetes and metabolism, and nutrition and metabolism. Over her 28-year career at NIH, Dr. Sumner has distinguished herself as a research mentor and leader, to which I can personally attest. We had a lovely lunch today, and she was giving us all the best career advice for how to manage our research teams, which I think everybody who was there can say was really helpful. So if you do get a chance to talk to her, she gives wonderful career advice. In addition to that, Dr. Sumner is widely recognized for her work evaluating current screening tools and guidelines and designing screening tests and early interventions to reduce the impact of diabetes and heart disease in populations of African descent in a portfolio of work that includes studies both in the United States and in Africa. Today, Dr. Sumner will be sharing some of her recent work in this area. Her talk is entitled, Universally Effective Screening Tests for Diabetes Require Knowledge of Diabetes Physiology. Welcome, Dr. Sumner.
Okay, thank you very much for the kind introduction. Thank you for coming to my lecture. And thank you for the high honor of presenting this lecture and for making me feel so welcome while I'm here. I'm going to advance the slides. I would like to use the screen if that's okay. Sure. Oh, okay, I can click here? I have to click here. Okay, just to... Yeah, so you can click. Okay, great. Thank you. And I'm going to focus today on screening tests for diabetes because I'm going to really focus on addressing undiagnosed diabetes. I'm going to talk about sub-Saharan Africa, and I'm going to talk to you about data I have from the Africans in America cohort. The Africans in America cohort are African immigrants to the United States. I'm focusing on undiagnosed diabetes because I want to prevent complications and I want to optimize chances for remission from lifestyle intervention, and that requires early diagnosis. Now, I think that all of our participants with diabetes have type 2 diabetes. I don't think they have type 1 diabetes because we get autoantibodies and C-peptide levels. I don't think they have type 3C because no one gives a history of having that kind of an abdominal illness. I know they don't have gestational diabetes because that's easy and the pregnancy test is negative. And I don't think they have type 5 diabetes because the lowest BMI of participants with diabetes was 22. However, in 2026, I've changed my mind, and I think that we have some participants who have type 2 diabetes superimposed on type 5. And the reason I think that has to do with my experience with the insulin-modified, frequently sampled intravenous glucose tolerance test. The way this test is done is that people are given a bolus of glucose at time 0. At time 20 minutes, they get a very small dose of intravenous insulin. The dose is 0.2 units per kilogram. So for a 70-kilogram person, that insulin dose is just 1.4 units. Now, I personally have done, between 1998 and 2016, over 1,000 FSIGTs in African American people and in white American people. and I never had to stop a test for hypoglycemia. But for the African immigrants, and this was 2016, when I was at person number 360, it was now the 10th person that this test had to be stopped for because of significant hypoglycemia. I thought the IRB would shut me down if I didn't shut myself down. This was a bad situation, and we didn't do any more insulin-modified FSIGTs. I actually thought back then that I had a clinical finding. I just didn't know what it was. But now I think it was those people had type 2 diabetes superimposed on type 5. I've been in communication with Meredith Hawkins about this. Now, what was I going to do, though, back in 2016 to get the data that I needed? We switched over to glucose-only FSIGTs, and that was in consultation with Richard Bergman. But we could not identify our parameters significantly. So then we switched to multi-sampled oral glucose tolerance tests, and you will see the results of those studies today. So since this is the Emory Global Diabetes Research Center and the Global Center for Diabetes Translation Research, I'm going to tell you about my experience with the Rwandan Health Program. In 2015, Dr. Agnes Binhuwahu, the Rwandan Minister of Health, came to NIH and gave the Barnes Lecture, and she spoke about the experience of Rwanda. And during that talk, she talked about the 1994 genocide against the Tutsis in Rwanda. And in 100 days, 1 million people were killed, 4 million people were displaced, and the healthcare system was destroyed. I can tell you that people weren't looking to the left, they weren't looking to the right, they weren't sneezing, and they weren't looking at their phone. And then she spoke about medical research and capacity building in Rwanda. After her lecture, she met with me, and she said, "What can you do for Rwanda?" And I said, "What can I do for Rwanda?" But actually, I was prepared for that question just somehow, and I said to her, "I can train Rwandan physicians to do what I do in terms of diabetes epidemiology with the African immigrants, and they can apply those same epidemiologic techniques to any chronic disease in Rwanda." Well, 6 months later, co-sponsored by the Rwandan government, NIMHD, and NIDDK, we had the Rwandan Health Program. In 2019, when Agnes Binhuwahu left the Ministry of Health and went to the University of Global Health Equity in Rwanda, we also moved with her. And it was a much better setting to do clinical research to be in a university. Then in 2022, when the University of Global Health Equity merged with Partners in Health, we also merged with Partners in Health. And that meant that we had to reach throughout the Rwandan country. And it made sense that the Partners in Health and University of Global Health Equity would merge because they were both founded by Paul Farmer, which, as you know, he left us too early. In 2024, NIH Fogarty Center became a partner, and we had this long, long name, so I like to call it the NIH-Rwandan Health Program. In 2025, we developed extramural collaborations with the University of Washington in St. Louis and the University of Maryland. And now our graduating fellows with seed money from the McDonald International Scholars Academy does primary research in Rwanda so that we can get pilot data to submit for international funding. And since it's 2026 and I'm here at Emory University, I think I need a new slide about our collaboration. Okay, so these are the 10 fellows that have participated in the program so far, with Bella in the middle being our current fellow. And just on May 12th, 2026, I got approval for a fellow to start in 2027. So I'm going to tell you about the research journey of the NIH Rwandan Fellows, and you're going to see our evolution of thought. In order to do that, I'm going to have to give you some background on diabetes in Africa. The projected increase in diabetes globally in the next 25 years is 45%. But in Africa, it's going to be 142%. That is the highest anticipated increase in the world. And what I'm concerned about is undiagnosed diabetes. 43% of people in the world are undiagnosed. They have diabetes. But Africa has the highest prevalence of undiagnosed diabetes in the world. And in fact, there are 3 African countries with 90% of individuals with diabetes who are undiagnosed. They're having progressive disease, progressive preventable disease and complications. But think just now about the 73% throughout sub-Saharan Africa, and please remember this number because it will come up again. Now, undiagnosed diabetes leads to late diagnosis and high mortality, and it is attributed to a lack of access to care. So if we're going to do anything, we're going to have to be cost effective because the amount of money spent per person with diabetes in Africa is less than $250 a year. It's not $250 a year, it's less than $250 a year. And so we are going to have to be cost effective if we make any recommendations, and it is not cost effective to have ineffective, inaccurate tests. And our thesis is that current screening tests are not optimal in Africa, and more primary research needs to be done in Africans. So in 2008, the section on diabetes, nutrition, and health established the Africans in America cohort. And we feel that working with diasporic communities is a novel approach and gives us an opportunity which we leverage in 2 ways. One is we can provide a physiologic basis for studies made, for observations made in Africa, and 2, data collected in America can allow us to do proof of concept studies as well as inform parsimonious study design. Parsimonious study design is a term that I came up with, and what it means, I should say a phrase, but what it means is what are the least number of studies you need to do in order to answer your question. So here in the US, we can use many parameters, but what is the least number that we need to use? That's parsimonious study design. And in addition, working with the diaspora community allows us to contribute to sample size contributions for studies in Africa because we're already studying Africans. So what we have is Africans in America and Africans, and we're creating a data bridge. So let me tell you about the fellows. Jean Utamata-Wishima was the first endocrine fellow, and right now he is the Minister of Youth in the Rwandan government. Together we wrote this review for Nature's Review, in which we highlighted how the populations of African descent are diverse, and due to genetic, physiologic, and cultural reasons, efficacy of tests vary across and within populations. So Damas Kaba-Kambira could demonstrate this. He was our second fellow, and as you know, waist circumference is a measure of visceral adipose tissue, which promotes insulin resistance, which promotes diabetes. Now this CT scan of the abdomen is what's up on the slide now, and the blue arrows show you where the waist circumference is. And the red arrows show you the visceral adipose tissue. All of that white is visceral adipose tissue. Now these 8 studies conducted in Africa all showed that the waist circumference, which predicts insulin resistance, is higher in women than men. What do international guidelines say? There's only one population in which the waist circumference, which predicts insulin resistance, is higher in women than men, and that's in Japanese people. For all other populations, they say the waist circumference, which predicts insulin resistance, is higher in men than women. About sub-Saharan Africans, they said, use European data until more specific data is available. So Damas looked at CT scans done at NIH in 375 Africans in America. So that's the largest CT study of abdominal fat in Africans anywhere in the world. And he confirmed that the waist circumference, which predicted insulin resistance in African women, was greater than in men. So this is key information for phenotyping risk, because screening tests require accurate phenotyping. And so working with the Africans in America cohort, we use technology available in the US and have validated studies done in Africa. That is the data bridge in action. What about undiagnosed diabetes and A1C? Regine Mugetti looked at the A1C modified diabetes prediction equation, which was developed in white and black Americans. And you can see the long equation with many variables. And what she found from working with the Africans in America cohort, that the A1C modified prediction equation had the sensitivity of 78%, but fasting glucose alone had a sensitivity of 82%. So you didn't need the whole big, long equation, and this is parsimonious study design. But what about A1C alone? And we found that A1C underperforms as a diagnostic test in Africans. In fact, the A1 sensitivity for the diagnosis of diabetes in Africans was only 30%. And that this was true even when people had normal B12, normal folate, and normal albumin levels, because we could get those variables and prove that they weren't affecting the A1C level. In addition, we know that none of our participants had anemia, and that because our participants got hemoglobin electrophoresis, we could retest A1 sensitivity without including people with sickle cell trait or hemoglobin C trait. So the sensitivity is only 30%, which is leaving 70% of people with diabetes undiagnosed. And that actually matches the IDF data that I showed you earlier about undiagnosed diabetes. And why is that? There's many reasons, but one reason is A1C underperforms is G6PD deficiency. G6PD deficiency is more common in Africans than African Americans and more common in blacks than whites. And this paper was just published in January of 2026. And what we found was that the assay for G6PD activity was better than genetic testing, because the genetic tests can tell you that a woman is heterozygous for G6PD deficiency, but they cannot tell you whether she is functionally deficient. That depends on how much X chromosome is inactivated. To know if a heterozygous woman is functionally G6 deficient, you need to A, talk to her, and B, get an assay. And then 2, there's the problem of rare variants. If the gene isn't included in the testing parameters, then you won't know. So we had a man who we said was G6 deficient based on his symptoms and the assay. But our genetic colleagues said, no, he is not G6P deficient. We said, this man is G6P deficient. So they got back to me and they said, well, Anne, there is a rare variant and it occurs in Gabon, only in Gabon. Where is this man from? Well, you can guess he was from Gabon. Okay, so this is actually an example of parsimonious study design because the assay is accessible and much less expensive than the genetic test. So, as I just said, and I am meaning to repeat myself because this will come up again later, the assay for G6PD activity is less expensive and clinically more important than the genetic test. I don't want to hurt anybody's feelings. Okay, now, beyond A1C, let's look at non-fasting markers, other non-fasting markers of glycemia. Now, you know that A1C is glucose irreversibly bound to hemoglobin. But then there's also fructosamine, which is any plasma protein irreversibly bound to glucose. And when that protein is albumin, you have glycated albumin. But which one do we use? So Jean de Duquetetti did a reproducibility study. 209 African Americans were studied twice, 1 week apart. And for fructosamine, even though fructosamine is old, it's no good because it's like flipping a coin when you got the test results 1 week apart. But for A1C, the kappa statistic was 90%, and for glycated albumin, it was 90%. So that's high reproducibility. So which one should we use? Oh, okay, right. So which one should we use? And the answer is, well, I'll tell you in a minute, but the key is, this is parsimonious study design because we know now not to invest in fructosamine. So which one do we use? We're going to use them both because A1C works in the obese and glycated albumin works in the non-obese. This was first realized from studies done in Asia. And here you see with A1C on the y-axis and BMI on the x-axis that A1C positively correlates with BMI. At the same time, glycated albumin negatively correlates with BMI. And what this means clinically is that A1C is insensitive at low BMIs and glycated albumin is insensitive at high BMIs. So we studied this in the Africans in America cohort, and A1C in the non-obese had a sensitivity of 36%. Glycated albumin had a sensitivity of 37%, and both tests together had a sensitivity of 58%, better than either test alone. When you looked at the obese, the sensitivity of A1C went up from 36% to 60%. You're not surprised because A1C performs better in the obese. At the same time, the sensitivity for glycated albumin declined from 37% to 27% in the obese. Not surprised because the sensitivity of glycated albumin goes down in the obese. And both tests together in the obese were only as good as A1C alone. But if you studied the two tests together without respect to BMI, then both tests together were better than either test alone, and that was a sensitivity of 61%. This was published in Diabetes Care, and after it was published in Diabetes Care, I contacted my friend Andre Pascal Kenye, who is originally from Cameroon, and he is now in Kenya. But at this time, he was the head of the NIDDK equivalent in South Africa, and he showed exactly what we had in our Africans in America cohort. A1C had a sensitivity of 63%, glycated albumin had a sensitivity of 53%, and both tests together had a sensitivity of 76%, better than either test alone. And this was the first example of how research done in the Africans in America cohort led to studies subsequently conducted in Africa. And now we're working on salivary glycated albumin with some collaborators in California. So now let's talk on about the etiology of abnormal glucose tolerance. Abnormal glucose tolerance combines diabetes and prediabetes into one group. The etiology is either insulin resistance or beta cell insufficiency. But what is the balance in Africans? In white and African Americans, we expect the majority to be insulin resistance. But working with Sajashimi, we found that 2/3 of the Africans in America cohort were actually had abnormal glucose tolerance because of beta cell insufficiency. And when we looked at the two groups, we found that the group that had beta cell insufficiency, even though they had abnormal glucose tolerance, they had a lower glucose and a lower BMI than the people who were insulin resistant. So that means the best diagnostic tests might vary by phenotype, race, and ethnicity. But wait, it's 26. and it's actually 3 physiologic subtypes and not 2. The beta cell insufficient group can be divided into 2, beta cell insufficient alone and beta cell insufficient plus insulin resistance. And that is shown in this graph of the disposition index. And we're not going to go through the different zones because we don't have time. But the reason I'm showing you the figure for the disposition index is that I want you to see that the derivation of the disposition index was as good with the multi-sampled oral glucose tolerance test as an FSI would have been. And this slide shows you how we feel different people may transition between insulin resistant to insulin resistant plus beta cell insufficiency, or insulin insufficient to insulin sufficient plus insulin, the 2 together. And we can go over this if you'd like in the question and answer period. But I want to move on to the oral glucose tolerance test. It's been around since 1979. And as you know, at baseline, we draw fasting glucose, and then we give glucola. And you can see over time, the people in blue have normal glucose concentrations, the people in green have prediabetes, and the people in red have diabetes. And note, fasting glucose is always obtained during an OGTT, and that will become, again, very important later. Now, we diagnose diabetes by an OGTT if the 2-hour blood sugar is greater than 200. But in 2024, the International Diabetes Federation said 2 hours is too long, and it's easier and better to have a 1-hour test and to choose 209 for the diagnostic cutoff for diabetes. So we said, where did this number 209 come from? It came from a meta-analysis based on a study of 35,551 individuals. So it was a very large meta-analysis with 0 persons of African descent. So we repeated the study and did an ROC curve to determine the 1-hour glucose, which best predicted the 2-hour glucose in the Africans in America cohort. And with an area under the curve of 0.95, the optimal glucose was actually 183. And 209 appeared over here on the curve. So when we divided the cohort by body mass index, the sensitivity when BMI was greater than 30 of 183 was 100%. The sensitivity at 209 was 78%. Not as good, but pretty good. However, when you looked at the non-obese, the sensitivity of a glucose at 183 was 88%. But for a 1-hour glucose of 209 and a BMI of less than 30, the sensitivity was 58%, leaving 42% of people undiagnosed. So that means the sensitivity overall for the whole cohort, independent of BMI, is 67%. And the majority of undetected by the 1-hour glucose at 209 did not have insulin resistant and were non-obese. And the majority detected had insulin resistance. So that brings to the question, are we going to need race-specific guidelines for the 1-hour OGTT like we do for the waist circumference and BMI? So we sent this to Diabetes Research and Clinical Practice, and for me, this was the fastest ever. We submitted it on June 13th, and it was published on July 26th. Now 2025 is here, and we're working with Simon Pierre Big Germani, and we said the majority of Africans with diabetes not detected by 1-hour glucose of 209 were non-obese and beta cell insufficient. Are we going to need the 1-hour OGTT to have different thresholds for different populations, or can we develop a universal diagnostic strategy which is independent of diabetes etiology, race, ethnicity, and phenotype? So this is actually a change in direction for our thinking, and we're moving our focus from heterogeneity to universality. These are the diagnostic criteria for the 1-hour OGTT for normal glucose tolerance, for intermediate hyperglycemia, which is the 1-hour term for prediabetes and diabetes. And I want you to note that they only focus on 1-hour glucose. These IDF criteria do not consider the influence of an elevated fasting glucose. And so the issue is, do individuals with diabetes not diagnosed by 1-hour OGTT who default to the intermediate group? And therefore, the intermediate group encompasses a broad range of risk. And so our proposal is, if the intermediate group were divided into two, based on the presence or absence of an elevated fasting glucose, would risk and therapy be better delineated? So, for the three groups, categories in the 1-hour OGTT, we looked at the Matsuda index, and Matsuda index is, it goes down, insulin resistance goes up, and it goes down across the three groups. But when you subdivide the intermediate group by the presence and absence of impaired fasting glucose, you can see the trend continues. And the same pattern was present when we looked at the atherosclerotic cardiovascular risk by the pooled cohort equation, and the same pattern continued when we looked at metabolic-associated steatotic liver disease. In fact, the group with intermediate hyperglycemia and impaired fasting glucose were exactly similar in terms of these metabolic conditions as the group with diabetes. So diagnostically adding fasting glucose to the 1-hour OGTT delineates risk within the intermediate group and does not add to the cost of the protocol because fasting glucose is already part of the protocol. And it offsets the need to identify all individuals with diabetes by the old 2-hour criteria because individuals with either diabetes or intermediate hyperglycemia can be targeted with similar surveillance and intervention. So we sent it to Diabetes Research and Clinical Practice, and we called it a commentary and said, call for a modification of the intermediate hyperglycemic classification of the 1-hour oral glucose tolerance test. Now, it wasn't published quite as fast as the other article, but we submitted it on August 20th, and it was published on November 10th. Now we said, in 2026, across many populations, we want to determine the diagnostic value of adding fasting glucose to 1-hour OGTT. So I reached out to your colleagues in India and worked with Pramod and Ram and Mohan, and I hope you'll come see our poster at the ADA. And what our preliminary data showed was that when the populations, our African descent populations now here represents both African Americans and African immigrants, and the South Asian population represents a clinic population in Chennai. And you can see by fasting glucose and area under the curve, the two groups are well delineated by fasting glucose. Home IR for insulin resistance, it's only the African descent population in which insulin resistance is better detected. When we looked at metabolic conditions, for MSLD, they're better detected by adding fasting glucose only really in the African descent, and for GFR, they're only detected in the normal glucose tolerance in the South Asians. So there are differences in the ability of adding fasting glucose to detect differences. However, I don't think it adds it doesn't lead to overdiagnosis, doesn't add to the cost of the test, and increases the universality of the test because it detects a group that would otherwise not be diagnosed. So examining both fasting glucose and 1-hour glucose in the 1-hour OGTT, I feel holds promise in detecting undiagnosed diabetes and cardiometabolic risk. But what is the unanswered question? Are the results of the 1-hour OGTT reproducible? No reproducibility studies have been published. Should a test be released and recommended globally without this information? I have experience with doing reproducibility studies relative to the OGTT, and I published a study with RAM back in 2020, and we found that the 2-hour OGTT was highly reproducible for the diagnosis of diabetes, and that but for prediabetes, it was only moderate. But the key is, for the diagnosis of diabetes, the 2-hour OGTT was excellent in terms of its reproducibility. Now, we're checking out the reproducibility of the 1-hour OGTT to see how we'll do. It's a combination of both African immigrants and African Americans. They had 2 1-hour OGTTs, 10 days apart, and it wasn't as good. The reproducibility of the 1-hour OGTT in our population was only substantial. Now, for intermediate hyperglycemia, like prediabetes with a 2-hour glucose, it was moderate. But the key is, for diabetes, it was substantial. It was not excellent. Now, these are the glucose diagnostic profiles for each OGTT, OGT1 on the left and OGT2 on the right. And what you see is that there are 22 people out of 29 who are non-switchers. They had diabetes at both OGTT. What about the switchers? There are 12 people who had diabetes at one visit, but not the other. So this is how it would look in a grid. But the key is, there are 34 people that had diabetes at one visit, or the other visit, or both. How did the non-switchers compare to the switchers? The non-switchers had higher blood sugar than the switchers. In addition, when we looked at 3 different insulin-resistant formulas, the non-switchers were more insulin-resistant. That was true with HOMA-IR, HOMA-2, and 1 over the Matsuda index. Now, I looked at 3 formulas because HOMA-IR is the least expensive. It needs only glucose and insulin, and it's available by a formula that you can calculate in Excel. HOMA-2 is more expensive. It also only uses fasting glucose and insulin, but it's proprietary, and it is not free outside of a university setting. And 1 over the Matsuda index is the most expensive of all, because you need both glucose and insulin at fasting and 60 minutes. So HOMA-IR is the parsimonious choice if you want to do research studies and measure insulin resistance. So my conclusions for the reproducibility study is that diabetes diagnosis by 1-hour OGTT is better in the presence of insulin resistance, but it may lead to underdiagnosis in populations in whom insulin resistance is not the dominant cause of diabetes. Now, traditionally, once the diagnosis of diabetes is made by one test, we say, it is recommended that a second test be done to confirm the diagnosis. But now, to avoid the consequences of undiagnosed diabetes by the 1-hour OGTT in populations in whom beta cell insufficiency is frequent, it may be time to reverse this thinking. So we should determine the frequency at which 1-hour OGTT should be done when the initial diagnosis is not diabetes. So working with Bella, who is our 10th fellow, I sent this to Diabetes Research and Clinical Practice. I submitted it on May 6th, and I got my reviews back on May 11th, okay? Choo! And I would have already submitted my comments, but I'm here, my reviews, but I had to prepare this talk and go to the ADA, so I'm delayed in getting back to them. They, however, were not delayed in getting back to me. So what are my overall thoughts? Even as more information on reproducibility and the frequency of tests is needed, the 1-hour OGTT is a great advance over the 2-hour OGTT in Europe, United States, and the well-medically resourced areas of the world. But it is a no-go in under-resourced areas of the world. This is a rural clinic in Rwanda Glucola is not available. It's expensive. The 1-hour OGTT is labor intensive. People are not fasting, and it's not happening. Now, I didn't take pictures at urban medical clinics that I've been to in Kampala, Kigali, Dar es Salaam, or Yaoundé. But as you know, the rooms are big where patients are waiting to be seen. They're sitting on hard benches next to each other or in hard plastic seats next to each other. There's often standing room only and no running water. So it's a no-go. So what do we need for undiagnosed diabetes? I suggest to you we need a moonshot. What is the definition of a moonshot? It's high risk, high reward, and nearly impossible. And there is a difference between nearly impossible and impossible, because nearly impossible means it could be done. And it actually stems from the 1969 Apollo mission. And the most famous biological moonshot is the Human Genome Project, which cost $3 billion and took 15 years. But in our case, I'm looking for less glamour and global clinical importance. Now, for my moonshot, I want to focus on non-fasting markers of glycemia. A1C works in the obese. Glycated albumin works in the non-obese. We need studies across populations. We already have some studies in African immigrants and South Africans, and my goal is to work with South Asians, and these are your abbreviations, so I don't have to go over them, but let's do the study. And if glycated albumin and A1C combination is valid across populations, as part of the moonshot, we have to perfect point-of-care testing for A1C. At this time, the point-of-care testing is, the kits are poorly maintained and not reliable. And we need to develop point-of-care for glycated albumin. Glycated albumin, I can already hear a question in the audience, is not actually, it's been approved by the FDA. It's not actually available in the United States right at this moment. The American distributor is going to reopen selling glycated albumin sometime later this year. And David Sachs, my collaborator, who is the head of NGSP and clinical chemistry at NIH, will be speaking to them when we're at the ADA. And neither A1C nor glycated albumin have to be expensive as the moonshot, as the goal of the moonshot. If it was to be effective, then they could find ways to make it affordable, particularly if it was going to be in widespread use and production. And at the same time, we always have to be flexible. We can get to an idea that we really like, but it might not be the right idea. And if A1C plus glycated albumin doesn't work, we need to find other non-fasting markers. We do not have to stay in this situation. So remember, the assay for G6PD activity is less expensive and clinically more important than genetic testing. I think there's a way forward here. And I want to invest in research to determine unglamorous, feasible, effective tests which universally diagnose diabetes across etiology and race and ethnicity. And these are my groups from the last 3 years. And now I'm going to steal time from the question and answer period and show you some photos. This is a picture of a grocery store that I took in Cameroon. It is filled with sugar-sweetened drinks. It is filled with candy. It had chocolate-covered Oreos, something I had never seen before in my life. They had chocolate-covered Special K. In fact, they had maxi boxes of chocolate-covered Special K. We can laugh, but this is serious business, and sugar is big business. And as I was going to northern Rwanda, as it was sugarcane harvest season, as far as you could see, there was men going up and down the mountains with sugarcane on their heads. And when they got hungry, they took the sugarcane off the top of their head, they took out the knife from their pocket, which looked like a little machete, took a piece of the sugarcane, and would suck on it. And what's more, they offered it to me. And also, if you look at these men, These are the men that are going to get type 5 diabetes because look at their size, and they're sucking on sugar cane when they get hungry. So oil is big business, as we know, and oil causes war. Well, so does sugar cause war. And this is the front page of a newspaper in Entebbe, Uganda, when I was there on July 24th, 2019. And what does the front page say? Tanzania allows Uganda import sugar. So this is big business and causes wars between even African countries. This is the closest I ever got to gorillas in Rwanda. I do like giraffes. I'm able to laugh and have fun, and it's a wrap. Thank you so much.
Quick question. Since we have people online, do you mind going just to the microphone if you guys have questions?
Thank you for the great talk. I had a question about the prevalence of metabolic steatotic liver disease. Did the prevalence differ by BMI, weight, or waist circumference in your population?
The prevalence of MSLD goes up significantly with obesity, and it goes up significantly with glucose tolerance. So it's low in people with normal glucose tolerance at an intermediate level in people that have prediabetes by the 2-hour criteria, and 90% of the people with diabetes had MSLD. Using the hepatic steatosis index formula for the measure of hepatic steatosis plus one parameter of the metabolic syndrome. But that MSLD prevalence is actually in a paper under review at BMJ, Open Diabetes, is calculated based on formulas that were never developed or tested in, I know you'll be surprised, populations of African descent. So I'm applying for an internal grant at NIH, and we're going to be looking at fiber scans and direct measurement of hepatic fat and to see what formula cutoffs would actually be correct for people of African descent.
So I have two questions.
Okay.
So one question is, there have been so many papers in the last few years about trying to implement 1-hour glucose tolerance test for diagnosis of diabetes. And most of them do 1 hour and 2 hours, but I think it's more expensive. And we already have more than 40 million people with diabetes, so it will increase the numbers. And your data is kind of against using or at least in lean people, using the 1-hour glucose tolerance test. So can you clarify where we stand with 1 hour, 2 hours?
Right. Okay. Listen, I'm working on the 1-hour oral glucose tolerance to make it better because the world is going in that direction. And I say, if the world is going in that direction, how am I going to make it work in this population? I didn't design it and I didn't endorse it, but the IDF is coming out for it. Even in the Lancet article, within a few weeks ago,
Consensus?
they came out with 5 articles on diabetes in sub-Saharan Africa, and they made all of their conclusions based on the 1-hour OGTT. And if that's what the world is doing, I'm trying to make it better. But I don't actually even think it's a worthwhile test that's going to be done I don't think an oral glucose tolerance test can be done in the settings in which I described just now. I think we need, for diagnosis of diabetes in these low resource areas, we need non-fasting markers because people aren't even fasting most of the time, and they might have walked all night or many hours, and they're sitting in the clinic waiting to be seen. They're going to be chewing gum and drinking soda. I'm not a fan of it, but I'm working with what is being done out there to make it better. Because if we persist with this 1-hour OGTT, we're going to underdiagnose Asian Indians, and once again, the population that I know best is Africans.
So, yeah, So my second question is regarding the glycated albumin. We have done some work with glycated albumin, and we didn't have good accuracy compared to A1C, but it's expensive.
Right.
And so, what is the real
Okay,
truth
so
for using glycated albumin? Maybe for research, but would it be for clinical application?
oh yeah, I'm promoting this for clinical application. That's my moonshot. Don't you want to be on the road to the moon? Okay, now listen, see here, what's really important here is that, or we can look at here, it's even better. Okay. If we had done, let's go back here, sorry. If we had done our studies only in African Americans, we wouldn't have known about the value of glycated albumin because we would have had too few people that had diabetes that were non-obese. And it was the fact that we were studying diabetes in Africans in a population that would have diabetes when they were non-obese that we were able to detect the value of glycated albumin. If you look over here in our obese cohort, the obese subset, glycated albumin looks worthless. So if this had been a study only in African Americans, it would have looked like this. But because we had African immigrants, so that we had a mix of people that had both diabetes that were lean and non-lean, we were able to detect the value of glycated albumin. And again, if glycated albumin were to be, ordered by the hundreds of thousands, the price would come down. That price, right now, I don't see the price as the problem. The price is to determine the value of glycated albumin in the non-obese. And that's why I would really like to work with an Asian Indian population that also has this high percentage of people that have glycated albumin, that have diabetes in the non-obese. And glycated albumin can be run on frozen samples. And you already have the people well characterized. You already have the A1C, and I'm sure your A1C is NGSP certified, whatever it needs to be. And so we just need to get the glycated albumin done. How am I doing? Just need to get the glycated albumin done on samples that you already have, on the people that are already characterized, and we would know the answer. Because if we could just do it in South Asians and the population that you have, we would know, and we would make a difference.
So yeah, now I have some questions, and Guillermo is my mentor, so I have two questions like he had. So
okay, right, it's a competition. Good, I like that.
Let me start with my first question. The question is provoked by your title, that the test needs to be physiologically based. Okay, so when you think of the physiology, there are these two axes. There's the beta cell beta cell or dysfunction, and there's insulin resistance, insulin sensitivity. So when you think of the 2-hour glucose tolerance test, we clearly know the 2-hour probably picks up more of the second phase insulin secretion and insulin resistance, whereas the fasting picks up more of hepatic insulin resistance and some amount of beta cell insufficiency. But for insulin secretion, there are two phases. There is phase 1 insulin secretion, and then there is phase 2, which happens later. So don't you think the timing of the test, we are not paying attention to which phase we are picking up. So the 1-hour glucose is some sort of saying, oh, the 2 hours is too long, let's do something in between. So maybe a better test might be one that picks up first phase response better, like maybe a 30-minute glucose or a 20-minute glucose, okay, number one. So I think physiologically speaking, I don't see the sensibility of a 1-hour glucose.
Okay, well, you're asking me to defend that which I haven't promoted. I'm not promoting the 1 hour. Well, I'm just trying to be diplomatic when I say it's good in countries where you have people that have insulin resistance. This disposition index figure in which which is how we determined our 3 subtypes, because we don't do it by cluster analysis. We do it by physiology, is based on the 2-hour OGTT, of which I'm a big fan. So I'm not promoting the 1-hour OGTT. I'm not defending it. And when we do the curves for the 1-hour OGTT, you see for people that are insulin resistant, it goes up like that. For people with beta cell insufficiency, it goes like that. So I think if we're going to have an OGTT, it should be 2 hours. But like I said, I'm trying to work with the world as it is and how to make it better. So that's the first thing.
So again, continuing on the physiology theme, that's one thing. I think we should time the glucose measurement to pick first phase, glucose response, second phase glucose response, and insulin sensitivity. It might be different tests. That's one thing. So A1C is useless for all of those together. It clumps all of them together.
Right.
Number one. The second, a more complicated question, is I'm very inspired by the recent publication of the islet cell atlas, 299 pancreases studied across the country, where the three cells, the beta, alpha, and delta, it's the balance among them when it gets disrupted. So we have all along focused on insulin, but there is the alpha cell producing glucagon, there is a delta cell producing somatostatin, which is not passive. So as we advance the physiology of testing, those measurements also become important.
Right. So what I want to do with this undiagnosed diabetes moonshot is part one is decide who has hyperglycemia and diabetes, and part two is what is the physiology of their diabetes and how would we determine that? Would we determine that by 1 hour, by 2 hour, by pancreatic studies, by multi-sampled OGTTs? So part one with this undiagnosed diabetes is to figure out who indeed has clinically significant hyperglycemia, and then we have to determine the etiology. So it's actually a two-part question, and now it's a two-part moonshot, so I thank you for that.
Sure. And my second question now, the world has arrived at the stage of different subtypes, okay?
Right.
So my question to you is, we call them insulin deficient subtype, insulin resistant subtype, or the mixed subtype, etc. But then when you look at, say, diabetes, type 2 diabetes in youth, which occurs at young ages, the earliest abnormality you see there is insulin deficiency. So are they really different subtypes, or are they subtypes that we pick up during the different stages of the natural history? All diabetes starts as an insulin deficient subtype, and then you overlay insulin resistance. So maybe it's different natural history. So in which case, the primary testing should be for insulin deficiency, and then other things add on to it.
Oh, okay, I agree. Okay, so if you look at this figure, this is the insulin secretion index, and these people here, so the green people have normal glucose tolerance, the beige people have prediabetes, and the blue, purple, and red have diabetes. And I'd like to say that the blue and the red make purple, okay? Just pointing that out. Okay, so we know that people with insulin resistance can move down from zone 3, we've created these zones, from zone 3 to zone 2 because their beta cells get exhausted. But then we also think, and those are many long-term studies, but there have been no long-term studies in Africa, maybe where people that have beta cell insufficiency, we think with a little bit of weight loss in the United States, can transition then to a small increase in insulin resistance and then move from insulin insufficient alone to insulin sufficient plus insulin resistant. And so we divided these are the whole cohort, zone 1, zone 2, and zone 3. And this is NGT, prediabetes, and diabetes. This is both. This is NGT, prediabetes, and diabetes. So for the insulin secretion index, they're low throughout. For the people with insulin resistance, they have a fall in their insulin secretion over time. Now the people with insulin resistance in the across NGT, pre-D, and this is NGT, pre-D, and then they have high insulin resistance throughout, and they just have, over here, there's no difference. Now the people that are beta cell insufficient, as they move from NGT to pre-D to diabetes, they have a small increase in their insulin resistance. It's just a small amount, but superimposed on their degree of, but when they get a little bit more, they're over here in the combination. The disposition index is actually the same in the group that are insulin resistant and beta cell insufficient, because you know it's an equation. And which part? There you go. Now, why is it that do we think that people with beta cell insufficient could be moving over to the combined category? This is cross-sectional data, but as you move from NGT to pre-D to D, there's an increase in body mass index, just a small amount. Look at that. Not too much, though. But what about waist circumference? That's a lot of increase in waist circumference. So they're developing mostly visceral adipose tissue. And in fact, since we had CT scans in 555 people, we were able to show that their visceral adipose tissue went up. So that's why they're moving over just a small amount in the face of weight gain in the beta cell insufficient people. And in terms of the Africans, we don't have data in Africans or in Asian Indians when they come to the United States about how much weight did you gain since you've been in the US, because nobody weighs you on day one. But I can tell you that I don't ask African immigrants how much did you gain weight since you come to the United States. I don't ask that question. I ask, how much weight have you gained since you've come to the United States? And actually, most stressful to their system, they'll say, mostly in the first 2 years. Then it levels off, because there is so much food in the United States. And you know what else? I had a Rwandan who was non-obese, who we told had diabetes. And so I said to him, how many cups of tea do you drink a day? And he said, about 6. And I said, and how many teaspoons do you put in each cup of tea? And he said, about 4. So I said, well, that's a little sugar, little water with your sugar. No, what I said was, that is really good news, because now you have something to change. If you change that alone could make your diabetes go away. And he said, Dr. Sumner, you do not understand. Sugar in Rwanda is like gold. So, there you have it.
One quick question. In your presentation, you mentioned less than 1 hour in the 1 hour oral glucose tolerance test, less than 155 is normal. 155 to 209, you describe this an intermediate hyperglycemia. And more than 209, I guess, is diabetes. So your intermediate is pre-diabetes, 155 to 1.
Again, I'm repeating the International Diabetes Federation guidelines, and those are the guidelines written up in.
It's pre-diabetes.
Right, it's written up in this article right here. International Federation Statement on the 1 hour postload for the diagnosis of intermediate glycemia. And I think Ram is right there as an author. Okay, did I answer your question? Yes. Okay.
I just want to say thank you for the talk. My name is Ariana Mora. I'm an MD PhD student here, and my dissertation work, so I'm in the Department of Epidemiology, is actually around this same topic of identifying undiagnosed diabetes, but I work specifically within the U.S. In the U.S., again, similar to like the global populations, undiagnosed diabetes is going to be a healthcare access issue.
Can you put the microphone closer to you?
Closer, okay, sorry. In the U.S., just like it is in the global setting, undiagnosed diabetes is largely an access issue. So I fully agree with what you were saying about the OGTT not being like really sustainable and like plausible in these settings. And it seems that really the big benefit of OGTT versus A1C is the difference between sensitivity and specificity of each test. And you explored looking at these different threshold cutoffs that, you know, maybe we switch depending on the population for OGTT. And so I feel like the most reasonable next step is, I mean, are you also evaluating different cutoffs for A1C?
Okay, no, because I don't believe in A1C, as I told you, because it had such a low sensitivity. But I have come to the conclusion if an A1C is high, then it is indicative of hyperglycemia. But if an A1C is low, then you don't know. So it's more like when people don't have the diagnosis, you need to repeat the test to confirm it. So a low A1C does not give you information diagnostically, but a high A1C does.
Okay, thank you.
Thank you.
Hi, I'm not an epidemiologist, so be gentle. My question is more about a global health approach, like a systems level approach to targeting the specific increase that you said is expected in this region of the world for diabetes, and also just what we know about like the epidemiological shift that occurs as nations transition as we know Rwanda is doing. Given that, kind of taking your parsimonious approach to the most logical extreme, would it not also be applicable for those of us that are doing global health work to just consider that, or maybe even more specifically the Rwandan Health Ministry, to consider that all of Rwanda and all of Africa is target for like a widespread lifestyle intervention change just based on this categorized risk?
Right, and that's why, right, but it's hard to get people to do lifestyle intervention. So if you could, if you would incentivize them by telling them that they have diabetes. And we actually, we wrote a scoping review on diabetes remission trials that were done with people in which insulin, people could not be on medications to be in the remission trial. That's what the scoping review was. And then they had Taylor from England. They do these really extreme weight loss regimens where people had to eat like only 900 calories in special diets, and that's totally unacceptable and would be socially unacceptable to be done in Rwanda or any African country. But in fact, the other studies, there were about 6 or 7 other studies that we found in the literature that could be models for intervention and community speaking. And yes, we just finished a study in African immigrants where we showed that diabetes was increased in people who were married. And so the reviewer said, "You're saying marriage causes diabetes?" We said, "No, but marriage causes scheduled meal times." And so that also leads to weight gain, because everything is more formalized. But it also provides an opportunity to teach families instead of individuals. Because when even in our study, somebody comes, every person gets diagnosed with diabetes, gets an eye exam, and he gets a meeting with the dietitian. But what we need to be doing is talking to the whole family, and the whole family needs to be walking after dinner. The whole family, but the world is against us, the economics of it, it's big business. What is a grocery store? I never saw a grocery store like that in my whole life. They were selling what people would buy. That's what you're up against. Do we have chocolate-covered Oreos in the United States?
I think we do.
Do we?
But I think to your, I think to your point though,
Okay. It's big business.
No, I'm with you. And I think to your point, like in the grocery stores in Rwanda, they're not going to be like this huge grocery store with so many options. It's really like these smaller choices, and so it's more like extreme to see those things being represented.
Okay.
Well, good news. We have some light refreshments outside, so you have more opportunities to talk to Dr. Sumner if you have additional questions or want to chat about possible research collaborations. I just want to take 1 second to thank Wendy, who's outside, and Jeff for all of their hard work organizing this event, making the schedule, getting our food. So thank you so much. And I also want to thank our excellent speaker today for spending time chatting with us about her work. Thank you.
Thank you so much. It was a great, great honor. I really, really appreciate it.